Good afternoon, everyone. Good afternoon, everyone. Good afternoon. I just wanted to make sure that we gave an ample opportunity for our luncheon session to get started. So if we could have everyone's attention and quiet the room to give them respect, that would be fantastic. Thank you so much. Thank you. Well, I'm delighted to be moderating this exciting luncheon session. My name is Courtney Luong. I am a healthcare advocate, a longtime supporter of the National Minority Quality Forum and the Congressional Black Caucus Healthcare Brain Trust. It is with great pleasure that we are going to delve into a very important topic, biodiversity in healthcare policy. And with that, just to set the stage, I'm going to go ahead and introduce the topic. The World Health Organization states that health is a basic human right. That means not simply being free from illness, but in a state of complete physical, mental, and social well-being. So what is biodiversity? Biodiversity is often coined as the foundation for such human health, and it is a panoply of ideas that really truly falls into an ecosystem. In other words, biodiversity is in fact the basis of our entire ecosystem of healthcare. This includes from food to fresh water, climate change, disease eradication, physical exercise, traditional and integrated or holistic medicine, as well as spiritual enrichment. Our wellness, therefore, depends on a variety of factors from family, community, economic status, and access to care for all. So it is with great pleasure that I introduce the Biodiversity Health Policy Panel. Each speaker will be introduced, and they will share about 5 to 7 minutes roughly of their remarks on the topic, and then we will then open up to a very dynamic question and answer session. With that, I am truly delighted to introduce our first speaker, Dr. Wayne Riley, who is currently the president of the American College of Physicians. He is a native of New Orleans, Louisiana. He is one of our nation's most respected and accomplished physician leaders in American science. As the 91st president of the ACP, he serves as a leader of the professional home for all practice the specialty of internal medicine and its subspecialties. He is only the third African-American internist to ascend to the ACP presidency in its 100 years of existence. From 2007 to 2013, he served with distinction as the 10th president and chief executive officer and tenured professor of medicine at Meharry Medical College. In addition to his ACP responsibilities, Dr. Riley is also now currently clinical professor of internal medicine at Vanderbilt University School of Medicine. Please join me in welcoming Dr. Wayne Riley. Thank you. Sure.
Good afternoon. I'd like to begin my very brief presentation with an African proverb that is often comes to mind when I have the opportunity to work with distinguished members of our community as each of you, and that is, if you want to go fast, go alone. But if you want to go far, go together. And that's the spirit in which the National Minority Quality Forum brings us all here to think about the things that we are passionate about in terms of health care and health policy. And that's one of my passions academically and professionally, is how we can move policy, whether at the state, local, or federal level, to better serve all of our communities. In thinking about what I'd talk to you today, something very simple came to mind. This meeting is the last meeting in which we will gather in Washington, D.C., while Barack Hussein Obama is the President of the United States. And I want to emphasize the progress we've made, because sometimes when we come to these sessions, we talk about what we don't have, or the progress that has not been realized, or we focus on disparities here, disparities in various communities. But I think it's sometimes good to stop and see how far we've come. And thank God for the President of the United States and the work that he has done. So think about it, colleagues. With the Affordable Care Act, 6 out of 10 African Americans gained Medicaid, CHIP, or private insurance since the implementation of the Affordable Care Act. 8 million have gained private insurance through the federal exchanges. 500,000 African American young people between the age of 19 and 26 have remained on their parents' policies. I suspect many of you relate to that. 2.5 million gained insurance in total, so the drop in the uninsured rate just with African Americans is almost 8% in the short time that the Affordable Care Act has been in place. The other fact is that 95% of the rest of the African American community could be covered if they lived in a state where the governor and the legislature had expanded Medicaid. The news is also good for our Hispanic and Latino citizens. 8 to 10 Latinos have qualified for Medicaid, CHIP, or exchange plans. 9 million have private insurance today due to the Affordable Care Act. 913,000 Latino young people between the age of 19 and 26 have remained on their parents' insurance. The uninsured rate has dropped almost 10% in the Latino community, and again, 95% of those left out could be covered if they lived in a state where Medicaid was expanded. I'm sure Dr. Tran will mention this as well in terms of Asian and Pacific Islanders. Again, the story is equally as good. 8 million now with private insurance that had no previous insurance, with no copays, by the way. 500,000 Asian American young people have gained insurance through their parents. 2.5 million have gotten it in total, again, dropping the rate among Asian and Pacific Islanders another 8%. So again, and I mentioned in terms of Native Americans, equally as impressive. If I had to be critical of our community, colleagues, I would say we've been too weak-kneed about defending the President and the Affordable Care Act against the intellectual sophistry that has emanated through various quarters. The first thing you do to address healthcare disparities, colleagues, is you put an insurance card in people's hands. That is basic. And the President has done that. Now it's incumbent upon the rest of us to finish that race and live through that African proverb I began my presentation. So let's celebrate the progress we've made, knowing full well that there's progress to be made down the road. Thank you.
Thank you, Dr. Riley. We're going to have a little delay in the program in terms of order, but I'm going to bring forth Coltrane Stansbury, who currently serves as the Senior Diversity Analyst at Johnson & Johnson's Office of Diversity and Inclusion. In that role, he manages a portfolio of projects that support the company's global diversity strategy, including the Gateway to a Healthy Community initiative. While Dr. Riley gave us a macro view of biodiversity within the broader context of the political policy ecosystem, what Coltrane is going to do is to dive down into a specific case example of the importance of biodiversity in a real-world community context. So please join me in welcoming him as well. Thank you.
Thanks so much, everyone. Good afternoon. Is this the advancer here? Oh, this one here, got it. So I first wanted to thank Dr. Puckrin for inviting me here. I think this is my third time presenting, and I always am so proud to present the program that I'm giving an update for today, the Gateway to Healthy Communities Initiative. In doing so, and we talked a little bit about this theme of biodiversity, it's important to understand that we define biodiversity, as was stated before, by a set of issues or problems in healthcare that are multidimensional and that deserve a multidimensional approach, meaning various different ways of not just measuring the issue, but also addressing it, which takes different types of approaches from different areas and community needs, and finding ways to see things through a lens of not only the immediate, but how we can create long-term systemic solutions that are scalable and measurable over time. So the Gateway to Healthy Communities Initiative, which was founded in 2011 out of the Office of Diversity and Inclusion at Johnson & Johnson, it really set out initially to solve around childhood obesity. But understanding biodiversity going forward, we knew we needed to really figure out and understand a solution that really got at what we're considering to be whole child health. So we looked at some of the areas that really are affecting beyond physiology and the effects of or the contributors to exercise, and looked at the other areas of what we consider to be the epidemic. And the epidemic is bigger than just this whole idea around diabetes and diseases of excess weight. What we're talking about are the effects of a sedentary lifestyle, which includes physiology, but areas of cognition, emotion, and social health that are affected. Whereas one child or a group of children or a family or a neighborhood could be going through trauma, for instance, that affects not just a child's weight, but also their attitude towards themselves, their peers, and carries toward learning for those 8 or 9 hours where they're a part of a captive audience in schools and classrooms that will then have a trickle effect to others that are connected to that trauma experience. So the idea was for us to think through, how do we model and map the issue areas? All of the areas that we can consider to be these multidimensional problems. And we came up with this idea of mapping out whole child health according to sort of these 4 pillars of physiology, cognition, social, and emotional health. Knowing that our program initially set out as an exercise aerobic-based program, how can we also now think through the next dimension of programming, which is creating the right partnerships, the right leadership, the models, the systems, and the measurement to affect all areas, so that no matter where the entry point to the issue is with the child, we have a web of services and a way of monitoring and measuring success over time. With that, we created the Gateway to Healthy Communities Initiative. This whole idea of reaching unmet medical needs in the communities that need it the most really struck us as the ability not only to leverage our own resources, which are research and the fact that we have clinical effects within communities, but how do we put a stake in the ground in some of the most at-risk communities nationally? And we did so by setting out to create relationships in 5 initial cities: New York City, Atlanta, Houston, and Newark, New Jersey. In doing so, the idea was to create sort of a web approach where we would start with the entry point as schools, then begin to utilize those relationships with educators to move toward creating relationships with caregivers, moms and guardians, making the way of transitioning information from school to home, making homes that are multilingual, for instance, that are suffering with multi-disease states, being able to create a relationship through backpack instruction, connections with school nurses and home, digital connections with report carding, to make sure there's the right alerts, the right education, and the right touch points with parents and guardians, which then allows us to create a trust factor in relationships in the community with groups like the YMCAs and the Boys and Girls Clubs. And this sort of web of services creates the maximum impact that we were looking for. Now we know that Gateway has some sort of proof of concept. Let's look at what we've done over the past few years. We've been able to impact over 800,000 kids, roughly about 250,000 kids a year in the program, burning over 500 million calories altogether. All of that exercise and that activity has led us to the point of understanding that we've got to go beyond exercise. That exercise is showing us that kids are suffering with other issues, and that trauma-induced environment allowed us to start retooling our program. So that the vision for Gateway going forward, yes, it includes exercise. That is always sort of the entry point. Because the let's face it moment is that kids want to do something that's an intervention that's at least fun, that's engaging, and allows them to be in a peer-based environment where there is no competition, it's anti-bullying, and allows for sort of ease or a continuum of understanding of a child's issue when you have a captive audience of children. The vision for the program going forward is to move beyond just the physical programming. We know that the physical programming allows us to do things like add biometrics, be able to measure things like BMI and waist circumference. The future of the program, though, is looking at digital. We know that through our partnerships with Microsoft, for instance, we're having access to the cloud, where kids are able to stream information, get access to mobile information, and also look at gamification in real-time speed. This gives us the ability to go beyond the in-classroom solution, which is being projected through smart boards and laptops, and go into the home and the community and after-school programs. We want the ability to scale not just to our 800,000 kids, 250 a year, but to be able to reach millions of homes through digital. Those relationships are allowing us with Microsoft, for instance, to put 200,000 phones in the hands of mothers and caregivers and have those smartphones linked directly to health information, including J&J apps and Gateway content that's measurable and accessible through the home. The physical program still has to exist. We can't let digital replace the ability of having trust partners on the ground. Parents matter in the process of understanding and creating education, awareness, and capability with kids to be able to have courage to own their own health. Our content strategy, therefore, includes, new this year, creating a portal. That portal having the ability to connect all stakeholders, educators, policy owners, clinicians, parents, guardians, aftercare programmers, to be able to connect on programs that will allow us to have a repository of information that can be shared among all user groups. Those partners, some of which we've already mentioned, include community partnerships with the United Way, the NAACP, and the National Council of La Raza, who are already partners on our diversity front at Johnson & Johnson. Also strengthening our relationships with the National Medical Association, National Hispanic Medical Association, and American Association of Pediatrics, and our ability to share information and some of our findings from 4 years and the years that will come from more poignant data that will be collected through digital. And lastly, government agencies and social organizations, Congressional Black Caucus, Congressional Hispanic Caucus, and all federal and state agencies that are looking to look at measurable results in areas of higher outcomes in physical education and how that drives policy outcomes, like substituting PE in classrooms, or our ability to leverage school nurses, for instance, to be able to have one platform in states for making sure alerts are given in terms of health identifiers in the school and at home. So in conclusion, the Gateway Initiative is working. How can we then go forward in a new generation to help more children? We have to be able to look at how we can leverage community relationships, which are the trust factor, with the fun factor, as we call it, the ability to create content that kids can understand, will utilize, is measurable, and creates real results. Thank you so much.
Thank you. Perfect. Thank you. Absolutely. Thank you, Coltrane. Our next speaker is Dr. Tran. She is the president and CEO of the National Council of Asian and Pacific Islander Physicians. She has an inspiring 20 years of government and public health service, and she is recognized nationally as a visionary leader and compassionate advocate for the advancement of well-being for ethnic communities. She is on a number of boards and commissions and has completed her pediatric residency at St. Luke's Presbyterian Medical Center in Chicago. Without further ado, please join me in welcoming Dr. Tran. Thank you.
Thank you. Thank you, and good afternoon. Good afternoon, and good afternoon, Congresswoman Christensen. How are you? But thank you very much, Dr. Courtney, for the invitation to speak today during lunchtime. And that, it is biodiversity. I have been here for 5 years now, every year. And thank you for the inclusion. That's how I see it, as biodiverse. So, quick question. Did you have chicken for lunch? And did you choose the most colorful vegetable for your salad? That is biodiverse. So what is biodiversity? Biodiversity is life on Earth. It is who you are, it is what you do, it is where you are at the same time, and how we react and we depend on this diversity in our daily lives. We might not know that, but we are doing it every day. For example, and it comes with age as well. For example, chicken is being considered as medicinal, or ginger for your cold, sore throat. And now that I'm getting older, I'm taking now flaxseed with turmeric for my joint pain. So that's how biodiversity is about. It is that it happens in our daily life in ways that are not always apparent or appreciated. And only just recently, its value to human health was highlighted during the 2 days conference with the National Institute of Health, the National Science Foundation, and the Smithsonian Institution, and summarized by this quote: "The implication of biodiversity loss for the global environment have been widely discussed, but only recently has attention being paid to its direct and serious effects on human health." Very, very important. Biodiversity loss affects the spread of human diseases, causes a loss of medical models, diminishes the supplies of raw materials for drug discovery and biotechnology, and threatens food production and water quality. So it is very important that Dr. Courtney and the National Minority Quality Forum chooses this topic as, and then this issue on your agenda. Very much appreciate that. We all can recognize the most obvious benefit being the large production of the medication that we take on a daily basis, if not, for patients. That is derived from the natural world. Over 50% of commercially drugs are based on bioactive compounds extracted from non-human species, including some life-saving medicine such as, and being a physician and having a French accent, I have to apologize if you don't recognize the name first. Citarabine, derived from a Caribbean sponge, and reputed as the single most effective agent for inducing remission in acute myelocytic leukemia, right? Other examples of drugs from biological sources include quinidine to treat cardiac arrhythmias, D-tuberculin to help induce deep muscle relaxation without anesthetics, very important. Vinblastine and vincristine to fight Hodgkin disease, vincristine for acute leukemia in childhood, and combat digitalis to treat heart failure and other medication as well. So you can recognize that it is very much more than 50%, of what we need in pharmaceutical in drug. Animals at the same time also have been used as a source of medicine from ancient times and also current time as well, both from vertebrate and invertebrates. And the current percentage for producing essential medicine is quite significant, talking about biodiversity. One excellent example of successful drug development from a component of snake venom, which is that of the inhibitors of angiotensin converting enzyme ACE that you all recognize. So now that from the animal, let's go to the water. So the marine environment is another rich source of biologically active natural products of diverse structural types. An example, the sponge, and the name is difficult to pronounce, the Lufariella variabilis, producing relatively large amounts of monohalide that inhibits the action of an enzyme that's called phospholipidase A2. So with these presented facts, significant medical and pharmacological discoveries are made through greater understanding of the Earth biodiversity, and the loss of this biodiversity would be very, very much important for us to be careful and to discuss about that. The loss of that may limit discovery of potential treatments for many diseases and health problems and could have significant direct health human impacts. So very much appreciate Dr. Courtney and the National Minority Equality Forum to put this on the agenda for discussion. Thank you.
Thank you. Our final speaker is Dr. Eric Williams, who was installed as the first male and 12th president of the National Black Nurses Association. He is recognized as being the first African-American male faculty member when he began his appointment in 2001 at the Santa Monica College. He has a master's degree in nursing from the University of South Alabama, and Dr. Williams went on to serve as assistant professor of nursing at Dillard. He was the first male faculty member there to be hired as a nursing faculty member since the inception of the nursing program in 1942. Lots of firsts. He received his doctorate degree from Case Western Reserve University. Please join me in welcoming Dr. Williams.
Thank you. I would like to first thank the National Minority Forum for including the National Black Nurse Association to participate in such an important conversation. We have our executive director here and nurses from several of our chapters. I saw nurses from Baltimore, Pittsburgh, and DC. So I would be remiss if I did not acknowledge my colleagues who happens to make sure that the leader leads well. So I really thank each of them. The National Black Nurse Association, our headquarters is located here in Silver Spring, Maryland. We have 95 chapters in 35 states. As I heard all of the presenters talk earlier about biodiversity and ensuring that life is worth living while on Earth, I'm going to come from a programmatic thrust as to what can we do to improve diversity in the workforce, to ensure that diverse populations with diverse needs are well understood. And we've heard of all the documents that have been produced previously regarding unequal treatment, confronting racial disparities. We've heard of the Sullivan Report that talks about diversity in healthcare. And just somewhat a small amount of statistics that the current nursing workforce remains 83% Caucasian, 6% African American, 6% Asian Pacific Islander, 4% Latino Hispanic, 1% Native Alaskan Indian population. And the reason why this is important, because as we talk about creating a workforce that can relate to patients and understand the diverse needs. And as I think about this, I'm from New Orleans as well. When my first job was at Charity Hospital, and I had to really quickly learn how to interact with people of color, because I could not say certain things like, do you use illegal drugs if I was triaging in the ER, and do you use street drugs? I had to be very creative, and we talk about nursing and healthcare. We talk about nursing as an art and a science. And I'm going to focus a little bit more on the scientific aspect of nursing related to human responses to perceived and actual problems. So the National Black Nurse Association, when we talk about the artistic part of creating a culture of health, it's twofold. Once we need to ensure that minorities are entering nursing school, getting through nursing school, and then navigating systems very well to meet the needs of our populations that we serve that are often vulnerable. Once we do that, we need to create leaders in the area of not only academia, but researchers, scientists, because change is only constant, and it's important that we understand change as a complex entity in a complex world that we live. So the needs of patients, as I must say, I entered nursing school back in 1980. The needs of people are different than what they were at that time. The healthcare system has changed. It's more complex. It's difficult to navigate. So we need those research scientists to help pave the way to create what we call a culture of health. We have a lot of evidence, we have a lot of data regarding epidemiology, but we need to really work on surveillance. The National Black Nurse Association, we have several programs. We have programs centered around cardiovascular. We know over 50% of people of color suffer from cardiovascular disease. Childhood obesity is a problem in our communities. We have children with hypertension as early as 2 years of age. And that's very scary and it's very frightening. So when we talk about coming together to create a culture of health, we need to begin early in the elementary schools, just like we teach arithmetic, English, history. We need to really teach nutrition. More recently, I had a great niece and nephew come over, and it was very interesting that they were able to say, Uncle Eric, you shouldn't eat that. So we're talking about creating the next generation. So we have to really start early creating this culture of health. We have a new epidemic that we decided to focus on as the National Black Nurse Association. And we have women's health, men's health, diabetes, HIV. We have several programs. But one that's new for us is that we're addressing the epidemic of violence. We need to begin to see violence as a public health crisis, as it's linked to mental health, poor impulse control, and we have some of the answers to creating a safe environment. So we can talk about nutrition, creating safe neighborhoods. As I said, when I worked at Charity Hospital, we may have seen gun violence on Fridays, Saturdays, Sundays, every now and then during the week. But now we're seeing gun violence whereby we have 100,000 of gun violence incidents a year, resulting with at least 30,000 deaths. When we think about the psychosocial implications, the physiological threats to those who are left behind, having someone as a victim of violence. Now, you may not say it really affects you, but I think for each of us, this epidemic not only affects us with our tax dollars from a Medicare, a Medi-Cal standpoint, but it also affects us with our emotions. So it's very important that we look at the emotional aspect as well as the psychosocial and physiological aspects of violence. So it is a crisis, and we need to tackle that as a public health crisis. And in creating a culture of health, we need to come together and join forces to make a difference in the lives of others. It takes a village, and to whom much is given, much is required. In the National Black Nurse Association, we're willing to work with all groups to make a difference in the world that we live, work, play, and worship. Thank you.
So we're going to open up to the audience if there are questions for any of the panelists, but I wanted to take liberty of addressing sort of the first question. And I'll address this to you, Dr. Riley. You had given us a nice overview and context on the policy side. For the audience, do you think you can speak to biodiversity from the solutions perspective and what's really attainable for community members? Are there some action items that they can take back with them that can be done to help sort of advance this as an issue, as a cause, so that when they're going home, that they have a good key takeaway from the session?
Sure. In the context of biodiversity, we know that many of our minority communities are very diverse genetically. And that in and of itself sometimes can be a revelation to minority patients. How many of you have done the 23andMe genetic test? That's one of the problems in terms of the genetic future, in terms of precision medicine. We do not have enough African Americans with their genome sequenced in some way. And I worry about that from a policy point of view, that the advances of precision medicine are going to leave us behind. And we know that that's not a good thing. And so in terms of the biodiversity, that's a key biodiversity issue in terms of our communities being able to access genetic therapies that are showing great promise. So I worry about that. In terms of the environment, Dr. Tran went through a very nice presentation in terms of the environment. Many of you probably thought that lead poisoning had been dealt with many years ago. And now we have Flint in the news. But Gary will tell you, and some of you who are more expert in public health matters than Gary and I will tell you, there's probably a lot more other communities out there that have lead problems.
Yes.
And it's going to come out. That is a biodiversity issue, right, Gary? So again, you have to think broadly about this in terms of the policy. And again, that's why having these forums is very important to inform, discuss, and take action.
Thank you. Thank you. You spoke about Flint, and Dr. Tran, in terms of poor and marginalized communities, when you were giving that great overview in terms of from plants to water to all of the systems within our ecology that sort of impact our health, in terms of what solution you would recommend for community members to take back, right? So there's the practitioner level and then the community level. Is there one action item that you think would be helpful for these advocates to take back with them?
Thanks for the question. I was waiting for you to ask this question. Because that one recommendation, if not an action step.
Okay.
Because I like that better, recommendations, just I can do that, I don't.
Right.
But that action step, it is that education, that translation of the information that, at any level we have here to the community, because it is their lives. So to give you an example, that we have been using other plants for the medicinal food, medication production, right? But at the same time that people have been either overusing it,
Yes.
and that it will be, depleting either the planet or certain area. That so because out of either I feel that it's more like not understanding, not making the relationship. So example now that we have seen a lot of this depletion in these plants for medicinal purpose, but used in a very unorganized way. So for me, that action plan would be from the federal level, that how to educate, like one issue that Dr. Riley was saying, or my colleague, it is about the trial. At the same time, it is once we have the information that people will be more prone to be in the trial, to be in those clinical trials, to have a bigger picture and a better picture of the issue that the medication is on. So I do feel that education, reaching out and at any level.
Perfect, thank you. Are there any questions for our panelists? 'Cause I'm happy to keep asking them questions. Right here.
Good afternoon. My name is M.M. Martin with the Center for Health Equity and Wellness at Adventist Healthcare. So we've lightly touched on something I would call an elephant in the room, the idea of racism, and the impact of that on our health, and specifically around policy. And so I would ask you, what do you feel the responsibility of your organizations are in addressing racism and the impact of improving health, or the impeding of a culture of health? What do you think your responsibility and roles are towards that end?
I think that we need to first deal with the issue and be very open about it. If it exists, I think it has no place when you're talking about health care. It has no place in health care. We need to be able to confront the issue head on, to deal with that all people have equal access, equal care. And I think we all have had experiences on both sides of the coin. It doesn't make it right, but I think education is the key, that we educate people. And I can give you an example as a dean of, and this was a person that was from the Dominican Republic, and the person was teaching on oxygenation to nursing students. And I was there doing a classroom assessment for the faculty's tenure position. And the faculty member failed to talk about cyanosis, the bluish discoloration in patients of color to nursing students, which I thought was extremely important, the variations. So I think that when you see things that can be a form of social injustice or not sharing adequate knowledge, we have an obligation to address things to make sure that people are aware that it may be innocent, but we have an obligation to confront it.
Can I
Sure,
add?
absolutely.
I do believe also to add, to this question, it is. I think I do feel it is an obligation, of the government to take action, and that example, like like you were saying about the percentage, of the minority in any of the medical school or nursing school. It is that we have to look at that and see how we can bring the resources
Right.
to bring that number up. But those resources has to be done in a mandate way from the feds, or so it's. I do feel that it's a joint responsibility, of that accountability, that I do feel that.
Dr. Riley, did you want to comment?
Yeah, in terms of the major medical organizations, I'm very honored to lead one that has been very progressive in a number of areas. The ACP put out policy last fall on LBGT care, that we know there's significant disparities experienced by those in our communities who fit that. So we're very forward-leaning in that. In terms of diversifying the health workforce, we've signed on to the amicus brief challenging Abigail Fisher's contention over the latest scheme that many universities have embraced to diversify the health professions. So we've been very forward-leaning there. In terms of firearms, we joined with 8 other organizations, including the National Medical Organization, to put out very common sense proposals to deal with firearm violence. Now think about it. This is the House of Internal Medicine wading into issues with firearms, but we know that's the health of our community. Next week, we will be the first, and not the first, but the largest medical organization to put out policy paper on climate change. So we have taken a very broad view of the health of our patients. It's not just the patient in our exam room, but it's our patients, whether they black, white, Hispanic, lesbian, gay, straight, etc., that all of medicine and the healthcare system should address all aspects and all people equally.
Thank you for your question. Dr. Fagan? I'm sorry. Okay.
It's on. Hi, yes, my name is Farouk Saadat, and I'm from Howard University. Dr. Williams, you referred to the role of community violence, and our study has shown that we are doing it locally in Washington, D.C., African American male and female age 18 to 25, the importance and significance the role of community violence plays with regard to alcohol use, drug use, age of initiation, every other aspect, even gun violence. With that compared to at-home violence, community violence is so much more important and significant. And the research also shows the adverse childhood experiences, how that is important in community violence. Is not people just suddenly get mad and come and attack other people. Its roots in early childhood. And people talk about even screening parents when they come for visits to find out about their childhood experiences that they're not even aware of, so they do not transfer it to their kids. So I just wanted to know what your experience or your comments are about the role of adverse childhood activities.
Well, I think what we need to do, again, is look at more community-based research, and I think that education is the key to a lot of our problems. So if we work to make sure that people get a proper education, can go on and secure good employment, are economically stable. Because when you think about all of these social determinants of health as they're linked to untoward situations or occurrences in our lives, I think education is the key. We need to do more research based upon communities that are plagued with some of these violence issues. And for example, we say to patients all the time as a nurse, how can we plan your care together? We really need to go into communities and not tell people what they need, but ask, what can we do to make your life better? What are the tools for success in this area? Now, we have some of the answers regarding violence and problems in African American communities. One is that we need to go back to strengthen the family unit. I come from a very large family. Most people may think I'm an only child, but I will say I come from a family of 9. But there were certain things we had to do on Sunday, like eat together, although, there's a wide gap with some of them because I'm at the bottom. But I think the family unit and the value system has to be strengthened. Also, we know from research, children and people that get into a lot of trouble, they usually have no religious affiliation. They don't have a connectedness with a higher being of any sort. So we need to really look at maybe revisiting some things that had been around for years that we may have lost with this generational change currently in society. So I think education is the key, doing needs assessments based upon research, and once we identify the evidence, share it with the community of interest with upward stream interventions will help to diminish some of the violence in our communities.
Thanks, Courtney. I just want to thank the panel for an outstanding, comprehensive discussion of biodiversity and the collaborative approach. But I think Dr. Williams brought up the issue of violence as a public health problem and emergency. I know Dr. Edith Mitchell, our president of the National Medical Association, in her national colloquium March of this year, had a panel addressing that, emphasizing that we as NMA physicians need to get involved in that. I was just in Memphis last week. Their homicide rate is now 60, and there's a clear correlation between drug use, drug treatment, drug use primarily, and dealers. It's a drug war really going on. Could the panel address the issue of violence as a public health issue and the interconnection with drug abuse in the community?
Sure. Thank you, Walter. In terms of firearm violence, the first thing is that there's too many guns. And this is something that we've worked with the NMA and Dr. Mitchell and the American Bar Association and so forth, is to really focus on getting the guns out of our communities, because that's the substrate that generates, in addition to the drugs and alcohol, but the easy access to guns is really problematic. Again, one of the searing moments of my tenure as president was standing in the room in Charleston at Mother Emanuel Church where those 9 were killed. And you could still see bullet skid marks in the linoleum. And we were there on the 6-month anniversary to really try to push for more gun legislation. In the news, things are very painful, but even more painful. I just arrived here in D.C. Last Thursday. There was a young man killed at a metro stop, 16 years old. I mean, that ought to be animating us even equally, if not more, than Charleston. We know Charleston was perpetrated by a racist, nihilistic young man with lots of problems. But you worry about in the communities, Southside Chicago, New Orleans, my beloved hometown, that's, a Saints player was killed senselessly the other night. You name it, all the communities you come from. So drugs are part of it, Walter, drugs are part of it, but I think, the sine qua non is getting the guns out of our communities.
I'm Jeffrey Rudell, a doctor with the Undersea and Hyperbaric Medical Society, and my question concerns traumatic brain injury and national standards for recognition, definition, and treatment of traumatic brain injury, because some people in the medical field even deny that it exists. Do you have an opinion about that, Dr. Wiley?
Yeah, internal medicine has never denied that there's likely to be deleterious effects from chronic head trauma, even in recreational sports, football, et cetera. So I think, in terms of American medicine, we're there. The problem is the research is a little slow in that. So we need more research to inform the clinical decision making. I don't think that folks are denying it to the level that may be perceived, or that certain professional football organizations denied it for many years. So I think this is an area where we need research. We need minority communities to participate in that research in terms of elucidating the knowledge base that will then drive the clinical decision making to take care of patients with chronic brain injuries. Oh, one of the other things about chronic brain injuries, and those of us who've worked in emergency rooms know, seatbelts. That's one of the first things we can get minority communities to do to prevent head injuries, because the data suggests that Hispanics, Latinos, African Americans do not buckle seatbelts at the same rate that still. And again, you know, when you see a head injury roll into the emergency room and it's a Latino or an African American, you can, you know, it's just classic. So that's the most common way that you and I can have a traumatic brain injury, is by not buckling seatbelts. So again, that's a public safety issue, a very education issue in communities, you know, that again plays into what you've just posited.
I'm Thelma Henderson. I'm with the National Black Nurses Association. And I wanted to just ask a question about first of all, I'm very excited to see that the healthcare professionals are getting involved with this epidemic of violence. But one of the things that has concerned me, and I wanted to ask both of you, Dr. Williams and the physician, if you think this would impact your initiative. You know, one of the things that the American Pediatric Association has been doing as part of their assessment is to ask families if, in fact, they have a gun in the house, because they really just want to talk about gun safety. Well, the NRA and others have advised folks, don't answer that question. And in some of the conservative states that are controlled by conservative governors and legislators are actually putting forth legislation to make sure that physicians cannot ask that question, because it's all associated with people's rights to have guns, and they're saying that this is just a way of kind of getting into your business. So how do you see this impacting your initiatives as you move forward?
Thank you, Doc. Absolutely. The state of Florida, any of you who practice in the state of Florida, right now it's illegal for you to ask about firearm in the household. We have vigorously filed suit against the state of Florida and have filed on to a case that's at the appellate court level to push back. That's an infringement upon my First Amendment right as a physician to counsel my patient. So no, you have to be vigilant about those kind of laws that are pretty much ginned up by the National Rifle Association. That is perfectly within the purview of the therapeutic encounter, whether you're a nurse, a pharmacist, a PA, a physician, to ask about firearms. Remember, the number one issue with firearms generally in households is two: a young kid getting access to that gun, thinking it's a toy. How many times do we read that in the news? And number two, it's suicide. That if you have a gun in the house, it's statistically proven there's a higher predilection to suicide. So again, you know, we vigorously oppose that. And we will fight anywhere around the country where governors and legislatures try to impose what we consider to be physician gag laws with regard to asking about firearms.
I'm just going to ask you to hold your next question just 1 second. Dr. Williams had mentioned a culture of health, and just in the spirit of just wanting to make sure that you were able to flesh that concept out, you know, just a little bit more. You alluded to the workforce and important linkages within the broader biodiversity context of the ecosystem that we initially talked about with this panel. So I just wanted to make sure that I circled back with you specific to workforce, culture of health, biodiversity, just to see if there was a pearl of wisdom from a workforce perspective that you wanted to leave the audience with, since our time is coming to a close.
Well, I think that earlier I talked about having a diverse workforce to meet the diverse needs of individuals, because you do need cultural encounters, you do need that internal desire to solve solutions. When we talk about violence and education and assessment with interventions, I think it's important that we move beyond the rights issue and understand that guns don't kill, people kill. So, and sometimes we get those two mixed up. So I think we do need to make sure that we protect our children who are vulnerable. President Obama eloquently stated when he sent out the call for violence reduction, that we have all type of safety mechanisms in place on medication bottles. I went to Chase like a week ago to withdraw some money, and it kept my card because of the new chip. And I got a call the next day that said, we have your card. But that's a safety mechanism, okay? We're sending people to fight wars in the Middle East, overseas, and everywhere else. But we cannot combat the epidemic of violence in America. And it's a clarion call right now to action. Now, we don't have all of the solutions, but to begin the dialogue and the interactions is the first step. On April the 30th, it's National Black Nurses Day Against Violence. Nurses across the U.S. will have town hall meetings, rallies, and so forth to increase awareness that this is a public health crisis. So I think education is the key, legislative involvement, bringing all of our stakeholders together, faith-based, fraternities, sororities, anybody that you can think of, to create a healthy environment, one individual at a time, one family at a time, which will ultimately lead to a community, a culture of health within our nation.
Thank you. Quick question. We have like 3 minutes.
Sure, thanks. My name is Minister David Street. I'm the National Director for Faith and African American Engagement at Enroll America, the nation's leading healthcare coalition for the Affordable Care Act. And I truly appreciate the rich discussion, particularly around health disparities and mental health in minority communities, but specifically within the minority communities. I want to kind of bring up the topic of reentry and returning citizens. What does that frontier look like? It varies state to state, so how you kind of engage could be different, and what resources are provided are different. But what the frontier look like, and how can legislators and coalitions begin to kind of shape that and make sure that that voice is also at the table in these discussions? Thank you.
Thank you. I'm going to let Dr. Tran, you had some comments from the prior question.
Yes,
right?
I just want to add to the workforce. Because that for us, I believe that, it is great that, a diverse workforce, but I do believe also that the workforce for the 21st century medicine, that, it should be, has to include, a few additional characteristics,
yes.
Of a professional.
Yes.
So we do feel that, from my organization, we do believe that this workforce to serve the 21st century medicine includes a strong sense of leadership, because anyone who is in the field should be responsible, should feel that to be responsible of educating, of linking out,
yes.
and finding the information themselves.
Yeah.
The second one, it is that about, the teamwork. Because like you said, it is not, we don't work in silos.
Yes.
And community, whatever, this link, so that how can we work as professionals, as a teamwork that educate, that
yes.
share the information to the grassroots level in such perspective.
Perfect.
Because we cannot know everything,
right.
but when we work in team, we share the information.
That's right.
And the third one, it is about, to solve the issue, if not, to help alleviate the issue of, the gun, the violence. It is that, that those leaders should also know about the social determinants of health.
Excellent.
And that by doing so, they will
Can we
find
collapse those two
solutions
questions
for
together?
them.
Thank you, Dr. Tran. Can we take your
So-
question and maybe collapse the recidivism and your question together? Just
Certainly.
perfect.
I'm Dr. Edith Mitchell, and I'm president of the National Medical Association. I'm also a member of the American College of Physicians and other organizations as well. One of the things, and you've really given a perfect panel today with lots of activities that we can all take back home. But given the political arena now, with many primaries and caucuses ongoing, I haven't heard, or perhaps one of you might focus on and make some comments regarding the power of the vote. One of the things that we have not really focused on in the African American community, and that is the power of the vote. Years ago, there was a lot of information on it, and it is true now that African Americans participate in voting less than any other racial or ethnic minority. So, are there any comments regarding the power of the black vote in healthcare?
So can we
I can
collapse those
address
two
it.
questions together? Can we take recidivism and? Okay.
Real quickly, my God, if Ted Cruz and Donald Trump don't energize African American, Asians, and Latinos, I don't know what will. In terms of the other question, in terms of the reentry, there is that's another aspect of health disparities, that we know that the quality of correctional medicine across this country is lousy. Lousy, absolutely lousy. And so when those individuals do reenter the rest of society, they bring their health disparities back into the system. So again, we have to try to agitate for better correctional health care, because in many communities we know that the preponderance of those incarcerated are Black, Latino, and low income, and et cetera. And again, that's another health disparity that you've just highlighted.
And also regarding the Get Out the Vote, the National Black Nurse Association, we have a very strong health policy agenda. We are actually developing toolkits for our nurses across the U.S. to help work in their communities to get out the vote, so that we would have good outcomes in this election. So we're working on it aggressively.
Without a global environment that is both healthy and capable of supporting a diversity of life, the human population cannot exist. So please join me in thanking this fantastic panel.